Alex, can you hear me now?
Okay now.
We shall now hear the comments and reactions from our resource person, Dr. Michael Liquete.
Good afternoon, everybody. Alex, can you hear me?
To have a chat to, please come in. We have a chat to reception. Please come in.
Okay, can you hear me now? Can you hear me now?
Good afternoon. You're coming in now.
Alright, I'll give my comments regarding this issue that is for debate.
I'm saying, please come in. We're not getting any reception here.
Hello.
Wait. Okay, 6 in distance.
I will now give my comments regarding this very interesting debate. Alex, can you hear me?
Okay now. Loud and clear.
Okay, thank you. And this issue this afternoon involves the continuing evolution in the treatment of breast cancer. So one side is defending the merits of a modified radical mastectomy, and the other side is defending the merits of a conservative procedure. And as we all know, the standard of treatment now is still modified radical mastectomy. And certainly there are proponents who are saying that a lesser mutilating procedure such as a subtotal mastectomy, lumpectomy with axillary dissection, with radiation, with or without chemotherapy, would result in the same survival rate as in the standard form of treatment. And therefore, when one advocates a new modality of treatment, there must be some important reason why there is a shift from the standard treatment. And I think you and both sides raised this issue. And these issues involve what would be the survival rates of these patients treated by MRM compared to those with a less than MRM. So in terms of overall survival and disease-free survival. Well, it seems that from the PGH side, they only quoted 2 local publications regarding the survival rate of breast cancer treated by modified radical mastectomy, and that is by the series of Liquete and Laudico, showing a 10-year survival rate of 82%, and that's it, about 82%. And your side also quoted a lot of reports from the literature supporting your claim that a less than modified radical mastectomy would result in a better survival, in fact, even a better survival compared to modified mastectomy. Number 2 is the issue of local recurrence. The PGH side maintains that it's practically 0 local recurrence when it comes to stage 1. Unfortunately, again, I guess they cited only some very few local literature studies regarding this, and we have to admit that our figures from the local setting is quite limited in terms of the number of patients studied compared to those reported abroad, which I guess your presenter have reviewed quite extensively. One issue that was not raised by the PGH side and also by your side is, since you are adding radiation as your main modality of treatment in the conservative treatment, you cannot just remove, excise that small lesion and do nothing about it, but you're going to give a high dose of radiation to the breast. Your proponent did not mention to us what would be the unnecessary consequences following radiation in terms of deformity of the breast, in terms of cancer that may arise in the ipsilateral breast, as well as in the contralateral breast, as well as other complications following radiation therapy. I would like to hear that from your resident. Both sides did not deal in broader terms in terms of the complication that may arise from the modified mastectomy as well as the conservative treatment. Number 5, both sides cited literature regarding the acceptability of the procedure. That is, the PGH side said that for those who would be undergoing modified mastectomy, they will have a better peace of mind since they know that the cancerous breast has been removed. On the other hand, your proponent, your resident who proposed this, says that it's quite acceptable for these patients who will undergo a limited resection because of psychological effects on these patients. Now, from the PGH side, I would like to ask you, given a patient with the same situation, since one of your main arguments is that if radiation is not available, you will do modified mastectomy. Supposing it were available, would you advocate this procedure to a patient? Or would you tell the patient as part of your informed consent that there is such thing as a conservative treatment that may result in just the same expectation as you would have in a patient who would undergo a modified radical mastectomy?
Are you through with your comments, Dr. Liquete?
Yes. Yes.
Okay, can we ask first, since you threw a question first to the Zamboanga side, Dr. Lin, can you answer the query of Dr. Liquete regarding the side effects, long-term side effects of radiation?
When we chose breast conservation procedures, we should have an informed consent because we are presenting this as an option for selected patients who, as I said before, we don't want to endanger their lives. So since there are many studies run abroad that for stage 1 and 2 breast cancer, conservative surgery and radiation are as effective as modified radical, I would leave it up to the patient to decide for herself whether to take that option or not. And I would discuss extensively with her that radiotherapy has its complications, like sarcomas, which are very rare, rib fractures, which are also rare, and that with the modern radiotherapy facilities that we have using negative voltages, this one has a skin sparing effect so that cosmetic is not really affected.
Thank you, Maya. Let me now ask Dr. Pastor Celia to answer the question of Dr. Liquete regarding whether to still go for a total mastectomy in the presence of radiation facilities.
Since I am defending MRM, I would just like to say that our main concern with breast conserving procedures is the local regional recurrence. Now, as I have stressed, this occurs even in patients who have undergone radiation therapy after a breast conserving procedure. As I cited, this can go as high as 22%. I would explain this to the patient. I would give her the options of a mastectomy, of a breast conserving procedure plus a radiotherapy, the risks involved for each. Now, if she decides to choose whichever, then I would do what the patient prefers, since both would just give the same survival rates.
Thank you, Dr. Pastor Celia. We still have time